We recommend 40. 40, when you actually run the numbers, your risks of breast cancer start increasing at age 40. And that's why we recommend it. I do know that we recommend getting the mammogram every year. I'm fully aware, of course, that some medical societies recommend every other year, and I don't really want to haggle over that. I think you need to get it at every year is the best thing, because if you're going to catch it early and small, every year is the best thing. Either that or you just have to do it regularly. I do know that some people only want to come every other year, but you do need to get your mammogram. So that's starting with screening. We can talk about higher risk women, but maybe we'll let Kel talk.
Can I ask a quick question about the imaging? So
Oh,
sometimes I have women who say, I don't want to do it because of the radiation.
Mhm.
And can I do thermography instead?
Oh,
How can I
Oh.
answer those questions?
okay. Just a couple things. The radiation will start there. The radiation dose of mammography is very, very low.
Yes, I tell them it's less than the chest
And in fact,
X-ray.
there's a chart. I was going to bring it to you, but the point is, in fact, when you look at the radiation exposure of all the imaging studies, there's so many answers to that. One, if of all the imaging studies, CAT scans, bone scans, PET CT scans, mammography, first of all, is one of the lowest.
Yes.
That's the first thing. Also, getting a mammogram is equivalent to just about 8 weeks of background radiation. Because we all forget is that there's cosmic radiation coming through the clouds. There's radon coming through the ground, and we're all exposed to background radiation that doesn't harm us. So getting a mammogram, and they've actually crunched these numbers, getting a mammogram is like getting just living for 8 weeks. It's another thing. So you'd think that, there's so many things to say about that. Like if you're living in Denver, you have a higher exposure to that cosmic radiation. Do you think that they get more cancers because they're exposed to more? No, they don't. And that's really the point. So low dose radiation does not cause cancers. And that's my long-winded answer for that. So it's low enough. In fact, we have physicists who check our equipment. In fact, by law, we have to get it checked every year, every 6 months, actually, to make sure the doses are as low as achievable.
Great. And thermography.
Thermography is not FDA approved. Because it tells you about the different, I think it's related to the vascularity. What does it tell you? It tells you no anatomic information. It can be false negative. So there's an association of a positive thermogram with cancers, but that doesn't mean it's cancer. So there's a lot of false positives. You're still, even if it is positive, you're going to need imaging anyway to find it. So why bother? Secondly. Thirdly, if you have a tumor that's very posterior or not even positive on thermography, it's a false negative. It's not FDA approved, and there's nobody who endorses it. I think it's a waste of time.
I agree, but okay.
I agree.
These are the questions that patients ask me.
Yeah. I think that in regards to your point as a young woman, 33, worried about that, the Tyrex Cruise is a perfect model to start with. Other is consideration of whole breast ultrasound, although they're time consuming. You could find a lot of nothings that may lead to unnecessary biopsies, but also it doesn't pick up everything. Obviously, 40 is the starting point, unless there's a strong family history of breast cancer. Obviously, patients that present with a palpable change and are under the age of 40, then they'll get the diagnostic workup. And obviously, then that's where the majority of these patients that we probably find now being diagnosed under the age of 40 is a palpable change, because guidelines aren't going to say getting a mammogram at age 30 is going to make a difference. We're, the majority of women that are going to still get breast cancer, even though we're seeing younger women, are going to still be 40 and above.
I'm glad you mentioned that whole breast ultrasound, because I didn't know I could do that, because I always thought I had to say 10 o'clock, 5 o'clock and be like really precise for the ultrasound tech. So I didn't know this.
There's a couple things. So just about the screening. So I think it's just to be clear, because I know that people have questions about this. Screening is when you have no problems. And so that screening should start at 40. anytime you have a problem, right? Especially 20, even 20s, but 30s, you come in, we will start getting a mammogram starting age 30. Why do we start at 30? Because the sensitivity of radiation to the breast decreases like proportionally after the age 3, which is why we do that. Under 30, if you show up with a lump, we will start with an ultrasound. It's a very rare occurrence to get a mammogram under 30, even if you have a lump. Very, very rare.
Now, is there any reason to delay, like, for example, breastfeeding, or back when we were first getting COVID vaccines, they say, oh, wait, like a few months after for false
No,
positives?
we can actually, I'm glad you asked that. With the latest is that you can get your screening, particularly if you have a lump, come in anytime, okay? If you're screening, if you know you're going to like be done in a couple of months, then you can delay it a couple of months. But if you think you're going to be doing it for years, you can still get your mammogram while you're nursing. Yeah.
Yep.
And about the breast ultrasound, sure. Breast ultrasound is something that we do. And it's just to be clear, okay, so mammograms are still the first line for detection of breast cancer. Ultrasound is good. The reason why mammograms are the best thing is because, as we talked about, that all the science is behind the mammograms. Having said that, you can still pick up cancers under ultrasound, but what you will not see by ultrasound is microcalcifications, which can also show you the first sign of breast cancer. It won't show that. And also, we tend to use mammography and ultrasound complementary. So there's 2 types of ultrasounds. Like you mentioned, it's the one for the lump, which we call a targeted ultrasound. And then there's the screening, which is what you're talking about. Oh, what can I do for this lady who's only in her 30s and wants to get screened? Well, you could do that. You could certainly do that. And that's called a whole breast ultrasound screening.
Okay.
Yeah.
Okay. Maybe we should talk about what exactly comprises a tyrocusic calculator, because I don't think a lot of viewers might know that. So that basically takes into account your individual history. So, for example, your first period, how old you were when you had your first baby, how many pregnancies. It does have some family history. Like, does anyone have a history of the BRCA gene mutation in your personal history?
It doesn't take the BRCA gene mutation in.
Oh, it doesn't?
No, it takes family history, breast or ovarian cancer, and your first degree pedigree mostly, or second grandmother. So first degree pedigree means your mom, your siblings, and we'll also take in your second degree, such as your grandparents. It does take in prior breast biopsies, also menopause, premenopausal hormone replacement therapy, and then it calculates that. Okay, it's not. It does not take into effect breast density. It does not take into effect if there is a mutation in the family. It's one of uh, the calculators that we use to determine high risk. It's probably one of the most common ones that's available. We use a pad at the breast care center that
Tell you the
is
check-in.
the check-in that's
Yeah.
a little bit, it's a modified
It also
app.
takes in BRCA Pro or something, right? There's different
Yes,
models.
right.
Yeah.
There's several models. BRCA, you're probably thinking BRCA Pro, but any of them are a good starting point. What you want to find is that you've got a higher risk population than the average is what it says. And to calculated risk for insurance, they want to hear your risk is greater than 20% compared to the normal average of the risk of development of breast cancer is about 13% in a lifetime.
Yeah.
So,
Let's not forget about the men too, should we?
yep, male breast cancer does occur.
Is it 1 in 10, for every 10 women, 1 man? Is that the
I
statistics?
think for every
so
100 breast
breast
cancers
cancer.
diagnosed, there's 1 male breast cancer.
Yeah, the number's quite high. I mean, compared, unless there is a genetic mutation, specifically for men, it's pretty much genetic mutations are BRCA1 and more importantly, BRCA2, which is also linked with prostate cancer. But we do see male breast cancers that are just sporadic, just happen because they have breast tissue. So if a man sees a change, then they ought to
He
be.
had to have a mammogram. He had a great experience at the breast care center.
Yes, I did. It was wonderful.
Okay.
I enjoyed it tremendously.
Well,
But it's interesting that you brought up males, so I wanted to ask you something, doctors. What can men do to lower the risk or catch signs early before it becomes serious?
well, in most men, the majority of men almost all come in with either a palpable lump, and the lump's usually behind the nipple, or distortion, flattening, a change in the nipple area that they've noted. I just had one the other day, a gentleman in his 50s who just noticed that his nipple suddenly became flattened compared to the other side. There was a subtle change. The mass, even though the cancer was there, was much earlier, probably earlier than when we get the change in the skin and the nipple and a bigger mass. But that's because men have much smaller breast volume of the ducts and the lobules, and male breast cancers pretty much exclusively happens behind the anatomy of the nipple complex, where the nipple is and the breast bud. That's where their breast tissue is. Women, the whole breast is pretty much glandular is composed of glandular tissue. So breast cancer has a lot more
So,
tissue to
So
be
it seems kind of
involved.
easier to find
Yes.
in a man generally.
I know you just said that, but I wanted to kind of understand it a little more. So are the symptoms like similar, like a lump, a nipple discharge, or changing in the chest area itself?
Most of the time in men, um, are going to be a change in the distortion of the nipple area, the area, the breast bud, or a palpable mass behind the nipple. Where nipple discharge in men is pretty rare, almost never. And in women, the symptoms are much more occult. Unless there's a palpable mass, maybe there'll be bloody nipple discharge, distortion of the nipple area. But most women's breast cancers are detected by images, the majority of them, okay? Because because of the utility of mammography in promoting mammogram on a annual basis. And our job is to detect cancer at a much earlier stage, okay? And that's why we, really stress to our providers such as Winnie and all of the PCPs, the gynecologists and that, are cancer screening, unless there is a strong family history or a known genetic mutation, should be instituted at age 40 and continue on an annual basis. And to, we can talk about later we don't make a cutoff. You're 70 and you don't get a mammogram anymore. That's not the state anymore. People are women and men are living longer. But our goal is to detect cancers at stage 0, stage 1. We're not going to achieve that in everyone, but that's when the much different. Those are going to be asymptomatic cancers for the majority. They're not going to be something that a low percentage of those are going to be something that a woman feels. Compared to the men, the majority of it is a palpable mass or that change in the nipple area.
I love what you said about how imaging is key, because I have women, they come and they go, can you do a breast exam on me? And I say, well, according to the USPSTF, it's no longer recommended. And they say, I do my self breast exam. I go, well, that's great. But you still have to go for your imaging. My fingers are not as
find things you
sensitive.
can't feel.
Exactly.
Right.
Yes, where
so-
that
I mean,
idea.
we don't just,
That's right.
we
You find
don't
things you don't feel.
discourage women from breast self-exam, because some women will pick up
Yes.
their breast cancers. And occasionally you will find something that maybe they caught before we really saw it on conventional mammography. And that all has to come to do with the denseness of their tissue, et cetera, that could go on. So, or a PCP palpates something, and sends a patient over. I've got a lady I just saw earlier this week that one of the other PCPs felt something.
Mm.
Shout out to Dr. Weld. Rose picked up a cancer in a patient, and
Wow.
so patient will be back and we'll discuss it. So she felt, and then after somebody in the PCP, you guys feel something. Usually, if you show the patient, oh yeah, that's there. Yeah,
Mm.
yeah.
I had a question with just the male part though.
Oh,
So I know you were talking about the BRCA, right? Is that what
Uh-huh.
you said?
BRCA gene
yeah,
mutation.
yeah.
So if someone has a strong family history of it and he's a male, should he get tested for that mutation?
Consideration of sitting with the genetic counselor, definitely. Yes, if the family history has that mutation, then men and women in that family should be tested. Okay, doesn't mean that they're going to develop the cancer, but they may be carriers. Okay,
Oh,
so
I didn't know.
yeah, so
So I could pass it on to my daughter or
exactly.
Really?
Okay, let's say that your mother or father carried a BRCA2. That's most common for more than one for male breast cancer. Carries a mutation. Then you need to be tested. Okay, specifically for that mutation that your parent had. If you have the mutation, then your children should be tested. If you don't have the mutation, then they're not going to get that. Okay, so the only risks that they have are then based upon your significant others. Would be based upon
'Cause it
Winnie's
comes from
family
two.
because it comes.
I'm past that
Yes, I
stage.
know, but I'm trying to we're making an example. It's a, we're,
is this like a one-time test that goes on or you
Oh,
always
it-
get tested for it?
Well, your genes don't change.
Well,
Your
that's
genes,
not one.
but your family history does change. I'm sorry. Did you want to?
no, but the testing gets more updated. They're now, we talk about everyone knows BRCA1, BRCA2, they hear it, it's the most common. There are 13 genes out there.
This is the
Currently,
gene company I use,
Yeah.
Natera, for genetic testing.
and there are 13 genes related to breast cancer out there. And of those 13 genes, there's kind of a severity of those. And some of those 13 of those genes are also going to be linked to other associated cancers, such as
Prostate.
prostate for men, pancreatic, colon, uterine, what we call endometrial cancer, and ovarian cancer. And there's other ones minor, melanoma, thyroid, and even renal cell kidney cancer. But it depends on, it's specific to each mutation, is what I'm saying. Some of those aren't really linked. Some of them are. So it's important to, if you have a family history of that of mutation, that members of the family consider testing for those reasons, not only for their breast cancer risk, but also for the other mutation, for the other cancers that could be associated with that specific mutation. Okay.
So I want to make sure that the viewers understand what Dr. Cornell said because it's very important. So when people come in for their physical, we have a family history questionnaire that I make them update every year. And I sometimes joke with the women and I say, oh, is there any family history of prostate cancer? And they kind of look at me and I'm like, and they're like, well, I go, well, I know you don't have a prostate, but I go, but if you have a first degree relative or there's a strong, lots of prostate cancer, your dad, then his brother, and then your grandfather. I mean, like Dr. Cornell is saying, that can be linked in.
There's
to
an association,
right,
like
Yes.
can be.
correct.
There
And,
can
Yes.
be.
and they look at me very
Exactly.
perplexed, and I'm like,
right.
but it's
Yeah.
important. So
Right.
we're gonna do genetic testing now. So
Right, there's so many things we're discovering about genetic associations now. It's so sophisticated.
oh,
It's
and if you're
engaging.
Ashkenazi Jew,
Right.
Exactly.
so
So there are a lot of numbers that when in
do you-
doubt,
Oh, do you know what Ashkenazi Jew is?
No, I just never heard that in my
Okay, well.
life. That threw me off a little bit. I'm not gonna lie.
so Ashkenazi Jewish descent is a subpopulation of the Jewish culture. Okay,
Okay.
there, and actually when BRC1 and 2, the as we throw around BRCA mutations were developed, it was basically that population of Ashkenazi Jewish that they linked and discovered that they were where the mutation got identified first.
Really?
Okay.
Yeah.
And from there it expanded. Okay.
Wow.
So we know that people that are of Ashkenazi Jewish descent in the family should consider, even regardless of history, sitting with a genetic counselor in consideration of testing.
Yeah, if they check off that one box
Huh.
that they have that ancestry, you should get
So
tested.
I'm 2% Jewish. I got it from Ancestry.
We already tested you.
Yeah.
You're good.
All right.
And those are no
Yeah,
good. I would
yeah.
not
Don't
do that.
yeah. Yeah, ancestry.com, it does not help with
No.
mutation screening. Yeah. But
Well said.
what else can we talk about?
Well, I had a woman who asked me about breast implants. What do we do about the imaging with breast implants?
Do mammograms with breast
And what happens if it ruptures?
Okay. We do, and in fact, I asked Pat, our supervisor, we do 500 to 600 screening mammograms with implants a year. And I've been there for 26 years. I think there may have been one.
That
So
burst?
the ladies are trained in how to do it, and you'd be really impressed with how tough those implants are.
Okay.
I mean, they're not balloons, they're not water balloons. They're actually, by the time you're getting a mammogram, you've got a healed fibrous capsule. It makes it a little tougher than you think. The ladies regularly, we do them all the time. And
Yeah.
they're specific views, and they do not get ruptured.
Right.
So that's the first thing.
Probably if that implant that got ruptured was probably one that was going to
Oh,
rupture anyway.
I
Yeah.
think it should be clear. I'm not sure everybody knows. Like, implants are not forever.
Yeah.
They're like 15 or 20 years, and after that, they're a little friable and delicate. So
Yeah.
Okay.
I'd like to go back a little bit. So I know you ladies were discussing mammograms and things like that, and certain women had told me that they go through this real heavy anxiety before they go.
Mhm.
So how do you work with that situation to get them to do it? Because I always hear like Dr. Wong always talking about, oh, this person or that person didn't want to go because they're always talking about going to the machine and feeling the pain, or I don't want to deal with it. Can we do it another way? So how do you help the listeners and other people that are going to view this say, hey, listen, you need to get it done, but let's get over this anxiety? Like, how do you work with that?
Well, it depends. If they're starting in Winnie's office, I wonder, it'll be interesting to hear what you tell them, but I can tell them if they actually make it into our department, our mammographers, in fact, I asked them, they are the first line. They're amazing.
Yes,
They do an amazing job, and they're actually unsung heroes, honestly, heroines, whatever. And I asked them, I said, Julie, and I asked a couple of them, what do you do when they're very nervous? Because you have you talk them through it. You let the woman know they're actually in charge. You explain the entire thing. You tell them, okay, I'd like to put as much pressure on, but if you can't take it, we're not going to force you to do anything. And it's an interactive thing. And they're experts, and they can get almost every woman through that process. So you can tell them that the mammographers are trained in that, and they know just what to do. We don't force you to do anything.
Does it matter how the density of it, like, how does that work when you go in there? Is there more pressure to it, or if they're more dense in that area?
I think because just like we all look different, everybody's breasts are different, and some women are really exquisitely sensitive. I would say that if you're sensitive during a period, maybe you come after the period.
So that's why.
Yeah, right. I would do that because then
that's what I tell my
Yeah.
I
don't think the density of the tissue really affects the compression of that.
Actually,
Okay.
you'd be really impressed.
Because
really impressed. Some people who are very dense are not rigid, and that's just something you have to see for yourself.
Yeah.
I tell women to make it fun. I'm like, go with a girlfriend and then go for lunch after. And then you're getting it on the schedule, and then they're
Tell
like,
the mammographer that you're nervous. Tell them that you're nervous.
Just be honest.
And they know.
Well, why don't you share your experience?
Well, I got a few questions because these people have been asking me, so I'm like, I wrote them all down.
Oh, okay.
So they wanted to know what's the difference between a 2D and a 3D mammogram, and should women be asking for one over the other? And I'm like,
I think every place in Massachusetts, actually almost every place in Massachusetts is doing both. We do a combo, and we call it combination. And 3D is slang for tomosynthesis, and it's
a big word.
Yeah, but we use 3D because it's easier, but that's its own thing, and it allows you to see more detail inside the breast. So I think almost in fact, in the United States,
Yeah.
I haven't looked. It's like 90%, more than 90% of all sites have both because it is better. It
Yeah.
allows you to get more detail, decreases your false positives, increases breast cancer detection. So it's
Yeah.
better. Yeah.
But understanding, Marcus, is that also that I think the concept of it, what's 3D and what's 2D, is the procedure of the mammogram, the compression side to side and the compression up and down is identical. It's the same thing. In fact, ironically, I'll tell you a quick story real quick. When we first got 3D mammography, one of the philanthropy donors at the hospital, older woman, came in and she was so excited that, we got 3D mammography and that, people had donated funds for us to get it, before that, a lot of institutions got it around our area. And the patient came to see me, was seeing me annually and said, I didn't get the 3D mammography and I'm a little upset. And I said, Audrey, you did. I said, the scrunch, it's the same. It's not a different technique.
Oh, it's right. That's
Right.
exactly true. You
And
look
I
at the
said,
same
it's not,
projection.
it's not, it didn't change the way, I thought I was going to get something new.
Yeah,
Yeah,
unfortunately,
so it was
it's not,
kind of
yeah.
a
It's
funny story to
right. There's
remember.
not glow
So
lights
it's not
or
much you
anything.
need glow lights or anything. I think as I try to tell with patients, what the 3D is really the radiologist back in their workroom and they move the workstation and it's like they scan through
Right.
the breast tissue in a dimensional kind of thing similar to other imaging.
Mhm.
The procedure of getting the mammogram is no different. Okay.
Okay.
So so we do, everybody goes through when our hospital and probably the whole system wide, Beth Israel, Leahy, everyone gets, 3D mammography.
Okay. So what has been the improvement over the decades in the mammograms?
The
Oh, well,
imaging.
yeah.
Like,
Well, it started when not to date myself.
But you're only 40.
Yeah, right, exactly.
She just had her first mammogram. Oh boy.
Okay. So it started as film screen, and meaning instead of being digital, it was just like remember you mash, they have these films that you actually hold. Now it's obviously all on a computer. So that was 2005. I lived through all of this transition. So it started with digital in 2005, and then they had to do the study showing that digital is equivalent to the film screen. So we went from analog, that's called analog, to digital. Then tomosynthesis was what was that, like 2011? I forgot, like 2011. And so tomosynthesis has been around for a long time. And now, well, it depends on, then they've discovered breast MRI. And breast MRI, that's another conversation in itself. And breast MRI is generally, there's specific reasons why people get MRIs, right? But mammography is still the mainstay of everything. So and lately, the latest is you can do contrast enhanced mammography, but that's also a select population. So the images are better.
Yeah.
Right.
Yeah.
And the other tools we have.
And Dr. Cornell, I wanted to ask you something. So I understand that they move on and it happens step by step. Primary care, imaging, then to you. When a patient receives the call, okay, that something's found, what happens next? And
Okay.
how do you
Okay.
handle it?
Sure. So we have a unique situation because we have a dedicated for years breast care center where the images are done and the breast surgeons are all in the same unit, the office space. So we also have
imaging on one side. So we have an entire mechanism. So if your screening is normal, you'll get your letter. It now pops up in your portal. And then if it's abnormal, we have an entire mechanism to call you back. Within 5 days, you're going to get that call back. Like, okay, of all mammograms, 10% get callbacks. Okay. So that 10%, we take care of you, and we we schedule you. And but by the time you leave that callback, that's a callback exam, you will know whether or not everything's fine, which 80 or 90% of the time it's fine, or if you actually need a biopsy. If you need a biopsy, then we have another mechanism to actually, that's when the clinic gets involved. And then generally speaking, if you need a biopsy, no, not actually all 100%, our patients, if you need a biopsy, they'll see our clinicians, and that's when the good surgeons come in.
That was gonna be my next question. I was gonna say, what does a biopsy involve and how soon can a patient usually get
So-
Before we go there, though, I have a quick question for Dr. Lui. So, is there ever gonna, like, sometimes will there be, while the patient's there, you'll take a quick look so that they don't have to wait and do the 5-day callback? Because that's very
Anytime.
anxiety provoking.
Oh, okay. When the long and the short of it is we see 26,000 patients a year. So if you really want to screen everyone, and since 90% of them are going to be normal, we do something. You come and screen, you come in for your 15-minute mammogram, and then we'll read them. And our turnover is within 24 hours, 24 business hours, right? One day. The patients that are read the same day are generally the ones that have either they have a problem, they have a lump, they have some sort of breast problem, then they're scheduled that way.
Yeah.
Okay, I see.
Yeah.
The ones that we
Right.
kind of escalate the
Mm,
workup are usually those that are coming in with a problem.
okay.
Okay, the young woman with the palpable mass, the young woman that thought she just had a blocked milk duct, but it's not,
Okay.
etc. So those are the ones that get kind of escalated when we see that it's an obvious suspicion for a cancer. Okay, especially in the younger population, they can we have what we call our nurse navigator. There's always a nurse that's going to talk to these patients. Even our nurse manager, Nancy, will shout out to Nancy Littlehell, but all the nurses. But Nancy's very good about. She is uh, is trained as a nurse practitioner, has worked at BI with images in the past and biopsies, but she's very familiar with walking through the images with the patient, letting them know, what the biopsies are going to be about. And all the nurses do that. But when there's somebody that's going to be a highly suspicious and we have time, it's a communication. That's why we're in the same area. We can sometimes get them in that day, but they can usually get in within 48 hours at the latest to see one of us and have the biopsy.
Okay. How have surgical treatments evolved over the years?
Well, a lot's gone on. That's we could have a whole podcast on that. Okay, that's the whole thing. So a lot of things have changed in regards to breast surgery itself. A lot of techniques in regards to cancer management. Certain things in the women above age 60, we actually de-escalate a lot of early stage cancers. We don't necessarily need to test the lymph nodes, what we call sentinel node biopsy for small tumors, what we call tumors that are like under 2 centimeters, with favorable biopsy criteria, what we see on the biopsy. We also do other techniques in regards to combined what we call oncoplastic. We tend to hide our scars so that the breast looks pretty natural. Okay, there might be a little scar along an area of the border of the relar complex. We also, if a patient has very generous breast, what we call breast hypertrophy, and has been thinking about a reduction and they have a small cancer, we can utilize our plastics teams to do a combination of what we call oncoplastic surgery, where they actually get their breast reduction and they get their cancer operation. We do a lot of mastectomies for patients' preference or for treatment of their cancer. Today I had 2 bilateral mastectomies for cancer. One patient was very young, under the age of 40, that felt her lump, but she had opted for bilateral, what we call nipple sparing mastectomy, where we really preserve the whole breast skin envelope in the nipple areolar area, and basically that's the most aesthetic looking when with reconstruction. So there has come a long way, but I think the biggest thing in the cancer care is also that we have a lot of treatments based upon the stage, but in some patients we just have, like I said, de-escalation of what we used to consider even 5, 10 years ago for the standard management was for breast when women wanted the cancer out and they wanted to preserve their breast. We would, do what we call a lumpectomy, remove the cancer, get good margins, sample the lymph nodes under the arm called a sentinel node. Many times they would need to go to radiation. We also don't use radiation in every case anymore. So there's a lot of things that have gone on. These are guidelines no matter where you're getting your cancer cares. It's not that we're just making them up at Winchester. So I want patient people to understand that that are watching this. So, and I think we offer probably a very aggressive approach to things, but really with overall good outcomes.
Okay, God bless this doesn't happen to anyone, but you go in, you get a mastectomy. How long would they wait? Like, does it go through stages where you have to go get it tested before they go to the next stage of possibly having breast replaced? Like going in for breast
reconstruction
implants?
part?
Yeah, whatever.
Well, usually we try to, if a woman requires or chooses to have mastectomy, we give them discussion up front of the options. Options are what we call flat scar, which basically is just mastectomy without reconstruction, removal of all the breast tissue, leaving just a flat chest, where they can get a prosthetic and a bra later. The other option is mastectomy with reconstruction. So we offer them all patients with considering mastectomy or need a mastectomy, meeting with the plastics team up front. The ideal time to begin the reconstruction process, if the patient desires it, is at the time of their cancer surgery, okay? Because you're preserving that skin pedicle. You've got the plastics team involved. They know what's going on. We know that sometimes they can have the immediate reconstruction with an implant that day if everything's ideal. But sometimes they require what's called a tissue expander, which is like a temporary balloon to prepare because they may need radiation. They may not have the ideal anatomy for what we call direct implant, or they may choose the other alternative of reconstruction, which is eventual what we call autologous, where they get tissue from the usually the abdominal wall, a portion of the skin, the fatty plane, and the muscle that's brought up on a pedicle, either directly or it is brought up and the blood supply is sewn in directly to the blood vessels. So those are much bigger procedures, so those don't usually happen at the same time, okay? So it's a state. Many times reconstruction, as I caution anyone to consider, there's always tweaking, okay? It's not like even if you go to direct reconstruction, sometimes there are little things that have to happen during that, okay? So
I'm imagining viewers might question, because there's always a question about finances and insurance. And and you're already upset enough dealing with the cancer, but is there a difference in insurance coverage for that?
No.
Okay.
I mean, every insurance company is different. All insurance have their co-pays, their deductibles. And if there's any question, they should always check with their insurance company, but the insurance should cover this. It is, an option of their cancer care.
Okay.
And the option of consideration of patient opts for symmetry procedure or prophylactic mastectomy is there. Sometimes there are patients that, I can't screen every insurance company, and I always tell them to check.
Okay.
But I really don't have patients coming to me and nearly 30 years of doing this that have ever come to me and said, my insurance company did not cover this. And so I just don't see that happening. Okay. I think it is part of their options for care.
So I got a question, and this one's for me. So I continuously hear you saying radiation, radiation. But there's no chemo?
Well,
What
again, there could be. I mean, again, we have to, all depends on what you're going to need based upon the biology of the cancer, based upon the stage of the cancer, how big the tumor is, are the lymph nodes involved if we take the lymph nodes out, based upon a number of factors that get added in, additional testing at the time after surgery on the cancer pathology. And, some cancers do require chemotherapy no matter what, because those are what we call the triple negative, or some of the HER2 positive cancers will benefit from that because we don't have an oral agent, a pill to give those. Now, estrogen receptor positive cancers, early stage, a large percentage of them may not require chemotherapy. We do additional testing to determine if there's benefit to give chemotherapy. Okay, that are you going to be better and here at 5, 10 years with the addition of chemotherapy? And as I tell patients, it's based upon the biology. If you put 10 women with the same cancer size and estrogen receptor positive, and that not all 10 of them are biologically going to act the same. Some are going to be more aggressive and do benefit from chemotherapy.
Is there a specific diet or something that you would give someone before surgery? Do you tell them, hey, listen, stop doing this, stop doing that?
Well, we know that, and Winnie, you can say whatever you want to say about what you encourage your patients, but healthy lifestyle never hurt. We're all into that. There's a number of factors that go into, changing everything dramatically before an operation isn't going to make the outcome any different. Okay, it's already happened. We know that diets that are with lower complex carbohydrates, watching weight, exercise,
Avoiding
with
smoking.
Less alcohol.
obviously less alcohol.
Oh, I have a question.
And-
Just X-rays, radiation.
No, what really matters is if you've had radiation to treat, for example, radiation to your
Hodgkin's
chest,
lymphoma.
like Hodgkin's lymphoma, high dose,
Okay.
really high dose.
Yeah. But those are, I always caution patients that, are they going for this, don't jump off the cliff and try to change things all in one time. We also have, you can modify things. You just be cautious. The majority of us that will get breast cancer, who do get breast cancer, it's multifactorial. Okay. We know that, everything has a little, checkbox, that's a little higher risk. Oh, checkbox, that's a little higher risk. So I think the screening for the family history, we know that women that are a little overweight may be at higher risk because of the additional estrogen. But there are like I said, a number of factors that play into this. Just like all cancers. I think there's no diet that I can tell you is going to make your cancer do better or not do better. But we also have the advantage of what we call now lifestyle medicine to offer our patients to help with diet, exercise, even circadian rhythm, sleep patterns that also take effect of that we've seen. So, like I said, there are numerous factors for the majority of us.
So have you noticed that there's breast cancers being diagnosed at a younger age? And if so, talking about lifestyle, like why do you think that is?
It's, people ask, again, I've tried to put, I don't think I can put, any of us can put our
Not just breast cancers too.
right.
It's like
Colon cancer's occurring. And I think we don't know absolutely yet. I think it's a number of factors. As I said, we have can all have a theory in that. Are the processed foods that you grew up on, different? I think some of our
They
Gen,
always say it could be the weight and,
yeah,
you know.
our Gen X are maybe more watching their, what they eat.
Yeah.
I don't think
plant-
anybody has an answer yet.
Plant-based may be better, some of that is suggesting, but I don't think you have to go, some of these factors have already happened. I mean, cancer for the majority occurs because there's an alteration in the gene, whether a virus comes in. Did the COVID vaccine, did the getting COVID, did any of these things change any of this? We don't really know, and I don't think we can speculate. Yes, there is something going on in the milieu that we're seeing cancers at a younger age, but when are we going to know the absolute? I think it's probably it's probably multifactorial if you think about it.
Mhm.
Yeah.
I mean, for one person, it may be something else, and for another person, I think it may be something else, or we may just don't really know.
Yeah.
Right, that said, everything that everybody talks about of being healthy, like watching your weight, right, eating appropriately, sleeping right, health, lifestyle, medicine.
So that being said,
If
do you
anything,
think-
that could.
do you
at
think they'll
least
decrease the age of screening?
I mean,
Because like with colon cancer,
Yeah.
we've gone from 50 to 45.
well, we went to, we've been fighting for 40 a long time, and then
Fine,
the
with USPSTF,
OBGYN,
finally
yeah, they
changed it,
all
right,
went
yeah.
back to saying it
Even
was
the
got,
USPSTF is starting.
it's
at
still
40 now.
50, it was, they went to,
They started at
no,
40, they just changed.
for mammo,
yes,
they
yes,
went up
yes,
to
no.
50, so everybody
Oh,
went up,
gosh.
a lot of societies, and that went to 50, and we were like saying 50 is not the right.
Because you start talking and it takes years before they'll even go.
So do we begin the screening again at age 35? I don't know. I don't, I think the the percentage that you're going to find is going to be
Less.
less.
It's still less. even
It's
though
still
there's- right,
less.
exactly.
I think, it's,
It's
I
not
went to,
time, yeah.
Yeah.
and even getting the screening for colon at 45 is tough for,
Yeah.
I think encouraging at 50 is great. 45 is ideal, but
As a primary care doctor, I like to start planting that seed.
Yeah.
Like, when they're 38, I'm like, okay, you're 38. So just,
What is
the
it now, 45 for colon cancer?
No, I'm talking for
Yeah.
mammograms. Like, because, I don't want they come to me, they're like 40 years old and, 6 months. And then you know what I mean? Like, and then they're like, oh, well, I don't know. And then we have the same conversation the next year. And then by the time they get there, I've already lost 2 years.
yeah. And I've had some of the
Do we have
some of our gynecologists have sent patients at, their patients at 35, but then at 35, they don't get another one until they're 40. It does, I mean, I don't really,
Right.
that, it
Yeah, they
doesn't,
stopped recommending
Yeah,
that based
so-
on 35, exactly.
TikTok?
Well, some person just asked me, they said that, so they were looking at statistics and locations and saying that you two were working out of Winchester and so on, you Dr. One. Have you been seeing more people from like certain areas of cities and towns that are heading your way? Like Woburn
Woburn.
has this big thing, but from what this person said is a lot of people are coming from the Berkshires in counties like Norfolk areas and stuff like that. And they said that, from their research, they came out with they said a high age adjusted incident rate was female breast cancer in Massachusetts, Berkshire County, with an incidence rate of 44.3 cases per 100,000 people. So
I haven't seen that statistics, but
you guys base things on statistics, or to you it's just
So
people-
that kind of statistic is based on hundreds of thousands of patients, right? And so, or at least
have you
tens of
seen an
thousands, at least
uprise of it,
10,000.
like of breast cancer coming in now?
And you mean from certain locations?
No, just in general,
well,
like
I'd have to look exactly at our numbers. Our numbers through Winchester, what we see at the breast care center is usually we get about 250 breast cancers on average a year, give or take. Okay. And that's been pretty stable. What I do see more now is that I get patients coming to me from other institutions, okay, for seeing me in second opinion, or they can't get their care quite as quickly, or that so we have a kind of a referral pattern outside of just our catchment area.
Exactly. So you never know where
Now
they're coming from. We're
right.
not like getting all of Massachusetts. We're just getting our
Yeah.
local area.
I see
So
a
it's
lot
hard
of,
to say.
I see a lot of patients now from Ever Chelsea, which we didn't really see before, that they're coming this way. So
Are there any questions on there? I can't see that far.
There is. Nope, not at this time.
Okay.
Just a bunch of people logged on.
Okay.
my phone was going off because people can't find
my
me.
God.
Where's the
No.
YouTube?
No,
Oh, no.
right.
But it's gonna be up. It's gonna be.
I know, I told them.
Everyone's hitting my phone up right now going, I'm trying to log on.
I know. That's why my phone went off.
I'm sorry, Dr. One. You're gonna have to hit that. Somebody had asked something.
Drag the puzzle
What?
piece.
Huh? Yeah.
What? I don't know. Someone else wants to know.
No,
I
they
know.
don't care. Everyone.
Oh yeah, people are just watching. Do you have other questions, Felipe?
Yeah, somebody was just asked. Logged on my phone and I'm looking.
Okay. Yeah, no questions. Oh my gosh, someone wrote stop estrogen.
Okay.
Okay.
It's actually male that's asking. That's why he's asking something, but I'm like, this gentleman he's a little caught up with, so he's a steroid user. He was diagnosed with
Gynecomastia.
yes.
Sorry.
And
Anesthesia.
yeah, and then he stated that he also had cancer there. So
Not a risk factor.
yeah, so
Yeah.
now I'm like, okay,
What's the question?
Well, that's all he's making a statement on. Like, they made a diagnosis saying it was gyno, but it ended up being breast cancer, he's saying.
So he's lucky that he got it checked out.
Well,
What he's asking for is whether his steroid use is.
yeah, it's basically what he's
Well, it depends
saying.
on how long he used it for. It probably put him at increased risk, especially if it was a long-term use of it. Yeah.
He said he was doing trenbolone acetate and androgen. So basically,
It will promote gynecomastia, enlarge breast bud, the breast tissue in men, but there's a number of factors. Okay, we don't know exactly, but we know that probably steroid hormone. There are hormones in the steroid. Obviously, that's what they are. So can it increase? It alters the overall hormonal milieu in the person using it for men there. So if he was using steroids for numerous years, it could have precipitated his reason for getting breast cancer. So
one of the people, now it's a female, says, what about women on HRT over 50? Questions the probability of cancer.
right. Do you want to talk about hormone? Because that's the big topic right now. Should women have take hormones or not?
I'll answer. I'll comment a little, and then you guys. So I think the important thing is to differentiate if it's synthetic or bioidentical. I would have to say, and then also knowing if you contributing to cancer, like we're not talking about, or estrogen receptor, progesterone receptor. So I mean, I don't know. There have been studies that shown that bioidentical hormones can actually protect against breast cancer. I don't know what you guys have read about. What are your thoughts?
The problem with some of these bioidentical hormones that are not regulated, okay? Pellets are terrible because you don't know how much are in that and what else is in it. We just, I was just on a podcast by the American Society of Breast Surgery in about hormone therapy, breast cancer. And really, the best is probably the prescription from your doctor is the hormones themselves. We know that if you don't have a personal history of breast cancer itself, you don't have strong family history with a mutation in the family, et cetera, you're probably okay to take hormone replacement therapy for a while. Okay. We're not saying that, obviously the studies used to say, long-term hormone replacement therapy increased your risk of breast cancer, and some of that is being refuted. Okay.
I'm
If
sorry,
you
when you say prescription, you're talking like Prempro, like
Prempro, if you don't have a uterus, you don't need the
Mhm.
progesterone. If you have a uterus, you need to take, estrogen and progesterone. So yes, and at the lowest dose, the lowest dose.
This question might be for you, Dr. Long. It's a guy.
Okay.
Asking on pellets.
Can I just say one more thing? I
Oh,
thought there was
absolutely.
one more, no, I just want to clarify, you guys know more about it than I do, but short term, like if you're trying to deal with the short term menopausal symptoms, it's still probably okay.
Yeah.
Right? So.
Yeah. The risk
I think
benefit
that
you
might
have to
be
get, cognitive dysfunction.
But this is, so if they're on synthetic pellets, should they get off it?
Synthetic? You
Yeah,
mean
I'm
like
kinda
what does,
confused.
I'm not sure what that means.
Synthetic.
Because to me, synthetic means
It
it's
says,
like,
should I stop doing the pellets?
Yes.
It's the synthetic.
I
didn't
don't understand what that question
don't
means, because
understand.
synthetic is like, Premarin's like horse urine, that's synthetic.
So what type
So,
of pellets do you
there-
use?
They're bioidentical.
Bioidentical, so not synthetic. Okay.
Yeah.
Okay, I think they needed to know what the difference synthetic and bio.
So bio is like supposed to be more similar to your body's own hormones, and then synthetic is not. But yes, Dr. Cornell is correct that bioidentical is not FDA approved.
Okay. So any questions?
So in other words, it's still in flux. It
Yeah,
might be safe if you don't have extra risk factors, right?
Yeah.
there's
Yep.
a
And
lot of
maybe if
chatter
you need
about
it for
it.
short term
The lowest-
symptoms that are driving you crazy, maybe you could do that.
Yes,
Is that?
yes.
And the vaginal estrogen is also safe.
It
Right,
got
they-
your American Urological Association for GSM, genital
That's right. I heard that if you don't
syndrome
have,
of
you don't
menopause.
have to
It's such a
suffer.
terrible,
That's what I heard,
terrible
yeah.
phrase. GSM, genital syndrome of menopause, dry vagina.
Yep.
Okay, okay. So
You don't have to worry about that.
no,
But it can
No.
decrease the frequency of UTIs across the country, saving women billions of dollars.
thank you. Thank you.
There are good points about hormone replacement therapy that probably don't subject you to increased risk of breast cancer that we speculated, but again, I think having discussion with your, primary care provider, your gynecologist, and the lowest dose possible, the shortest duration as possible, and the benefits actually starting them at a younger age than it is to start them 5 years after you're out of menopause and really you've already struggled with the majority of these symptomatology, but you also have to have that discussion. So, there are benefits, cognitive issues. People don't sleep. They're miserable because of the hot flashes. They can't concentrate.
They get moody and they yell at their partners.
Yeah, they yell at their doctors. No.
So
So if you go-
someone,
wait,
someone
I just
you
gotta-
know wants to know something.
Okay, wait, but if you go on YouTube and on the FDA site, they did have a great 2-hour discussion,
Mhm.
panel discussion in July. I think it was July about hormone replacement and like how they're refuting the findings of the Women's Health Initiative
Mhm.
and things like that. Like Dr. Cornell was saying, like perhaps we should reevaluate. And then they also did say there's no benefit if you start it too late, like you
Right.
miss the train.
So there's a question that just came out
Oh boy.
because it's obviously about the HRT,
Mhm.
the
Mhm.
pellets, because Dr. Cornell had said not a positive reaction from it. So would like to know why you believe it's either, I don't want to speak for you, where are you on this with
But she's-
this
yeah.
whole ordeal? I don't want to speak.
So
for
the
you, I don't
issue of the
speak-
pellets, my understanding, I don't prescribe these, even the bioidentical one, and this is based upon the Society of Breast Surgery and a recent podcast that they have, where specialists in this field, breast, OBGYNs that also do breast, are also trained in breast care. And basically, the pellets are very unregulated in regards to the amount of the hormones there, because again, they're not FDA regulated. The bioidentical compounds that are not in the pellet form, they're still not regulated, but there's a little bit safer of understanding. My understanding it is, it's not ideal. The Society of Breast Surgery and that we feel that it's best to take prescribe, FDA approved HRT therapy.
Okay, so which would be sub-Q?
No,
No.
like the patch or like
What has
Okay.
been,
So the
Premarin,
the
Premarin,
patch.
Premarin,
yeah,
Okay, so Dr. Wong, obviously you're in that field. So obviously.
We're gonna get into
No, no,
controversial.
No, but what the conversation is, because you keep saying the word bioavailability,
Bioidentical.
and they wanted to know, like, obviously you deal with a company that does tests, that does do all these things. And you're hearing Dr. Cornell saying, well, it's not FDA and it's not this and that. So the question is, how do you feel about it? Because it could be something that educated on both ends of it so people can understand the good and the bad, as anything.
I mean, I feel like the synthetic there, I personally do feel like there's more risk of like blood clots and possibly cancer than the bioidentical. I feel like the bioidentical can actually be anti-inflammatory and have and no risk of blood clots. So I do think but it is true it is not FDA approved, but I do feel like it is a safer option. But that is my opinion.
I know less about this. I just know, I know what Peter Ricci said. I think that whenever you're taking anything, you got to be careful about why you're taking it. If you're going crazy and need short-term estrogen, I think that maybe that's good for you. It's the longer term stuff. I mean, these things are real. Blood clots are real. They can go to you. I mean, so the risks can be real. Also, I still personally, I wonder because sometimes there are breast cancers that are estrogen positive. Like, so what if you're like you've got a breast cancer that you don't know
Mhm.
about, and then you're taking hormones? This is not answered to me. That's since you asked. But I'm less familiar with the literature.
Well, the Women's Health
Yeah,
Initiative, they stopped it.
But those are
early.
the things I
Yeah.
think about.
That's what they're touching base with. They want to see if the effects of being on this is going to cause a cancer and what the factors are.
maybe
Like, should they get tested?
maybe it didn't cause the cancer. Okay, I will say that. I don't think that being on these lower dose, whether it's bioidentical or prescription written for, FDA approved medications, necessarily cause or cause completely cause the cancer. Maybe the cancer occurred sooner than what was the predicted. I think again, it's we don't know. Okay. I mean, if you're on high dose hormone replacement therapy for 20, 25 years, still, even though we've said that may not be a real risk factor, we know it is. I mean, it's got to be. I mean, it's contributing. Okay. Our bodies are supposed to shut down estrogen production when we go through menopause.
What I can say is if you listen to the FDA YouTube, is what they said was with the Women's Health Initiative, in 2002 or whenever when they stopped the trials, because they thought it caused breast cancer. And when they go back and look, there was actually no direct correlation that like Premarin actually caused it. Is that right?
Correct.
There was no like, so there's no direct correlation. So that they're trying to refute that. The FDA is trying to refute that. So that is 100% like, no, not.
So that I think what's harder is to make a blanket recommendation for everybody. Is that right? And because of the factors that you're talking about, that's why there's so
Yeah.
much.
Controversy.
You're right, exactly.
You're
Because I
like-
think now we're at a
Yeah.
new era where we have to take a look at it going forward and maybe find some populations
Yeah.
and doses that are safe, FDA regulated, and then everybody can be comfortable with that.
You see any questions?
It's
So-
shared decision making. I think it's really what the key is to healthcare today. It's I mean, there's so much, data out there with media. You can go on YouTube, you can Google, you can, chat GPT. All of this is that you got to go and have the discussion with, your primary provider, your breast surgeon, your gynecologist, or what. You've really got to have it's informed decision making. Okay. I have patients that are miserable that come in all the time. My gynecologist wants to know if it's okay if I go on vaginal estrogen. I said it's perfectly fine. Go on it. Do not be miserable.
Yes,
Okay.
absolutely.
The risk of you getting a breast cancer because you're on vaginal estrogen, I mean, I showed them, I explained it to them why it's not going to happen. And if you need low dose hormone replacement therapy because you can't sleep at night, you can't think, your hot flashes are so
Yeah,
bad, you've
recurrent,
tried
yes.
everything else, then you've got to make your we're not put in this world to be miserable because we're making these decisions, okay? So I think, it's informed decision making. You have to decide in your life. It's like, if I don't, am I going to cut down and not drink alcohol, or am I going to have a glass of wine periodically? You make those decisions. It's your lifestyle choices. And that's why I really strongly talk to my patients when they're going through their cancer diagnosis or they're with me, is that, these your cancer happened for a number of reasons, okay? And you don't need to make yourself miserable, okay? You need to survive, but the most important thing is, and you need to choose, choose smart decisions. But, I'm not telling you you can't have a glass of wine with dinner. I'm not telling you you can't, have a dessert every now and then. It's all these things that you'd have to
Said
kind
a glass, Dr. Wong, a glass.
I didn't. I'm not going into that. Okay. Doctor, it's okay. We can talk about the Europeans, okay, and comparing it, okay? We can go all into that.
Is it six ounces or?
Yeah, we're out. Is it a Cortino?
I have such an interesting, well, she just said you can have a quart of wine. This is
I
an
didn't.
interesting question, and I don't know. I'm gonna be honest with you, I kind of avoided it, but because he keeps asking, he
Gyno
brought up,
guy?
huh?
Is it gyno guy?
No. So because you know how I work for the department. So when I
Mhm.
worked for the department, someone had a loss in his family. So this is probably about 2 decades ago. And they said that the mother could have survived, but didn't survive because they were diagnosed with breast cancer, but because they opened it and oxygen hit it, it traveled through the whole body.
Oh, gosh.
So that's why I
No.
kind of avoided that. And
Yeah.
the person said, "Oh, my mother was killed because they opened her up and it
Well,
spread everywhere." So that's
yeah. That's
There's no
it
truth.
obviously is a fallacy. If you think about it, then we wouldn't be doing surgical procedures on any cancer, because if you touch the tissue and the cancer is going to go crazy, that's not what happens. We know that. We do, Dr. Lui does, and her associates do what we call percutaneous or minimally invasive. They take a piece of the tissue, which if it's a cancer, they're removing a piece of the cancer for tissue diagnosis. It doesn't make the cancer start escalating and grow. It doesn't make the cancer travel to the lymph nodes, travel elsewhere. We know that's absolutely not, there's no truth in that.
okay.
I mean, we've been treating cancers operatively, and I'm not just talking about breast cancer, for years, okay? Really what it is, yeah, Yeah.
So oxygen hitting it. the
Oxygen,
doc-
no, oxygen is not, no, oxygen is good in many ways. We all need it.
Okay, okay. Well,
Okay.
I texted him and I said, well, there's your question.
Tell
on
him,
that
tell
one.
him to breathe. Okay, okay, it's all gonna be good.
Lots of oxygen.
Yeah.
Tommy, breathe.
Well, I am sorry that happened to his mother, though.
Yes, but we're sorry, yes.
But
Yeah.
it's just, you get these questions and people want to get it out.
I know, and there's, yeah,
And I extend such apologies that we're unable to go live right now, but it's gonna be dropped in and people can leave questions
Yeah.
and people can go. I had no idea that it got locked out. And I
Yeah.
do extend my apologies so bad because I do have a lot of people that are logging on and now they're all texting me.
well, if
And
you
I'm
want us to
like,
come back for part 2, there's that,
listen,
you know.
come back tomorrow because my IT guy's showing up tomorrow. And he's like, I'm gonna fix this and we're gonna go live. And that's it. And I know Dr. Wong's gonna yell at me and go, I can't believe this. I can't believe I had that.
Things
too
happen,
bad."
you know, there's technology, you know, Marcus, we heard that you're like the master.
No, well, Marcus is the master. That's why he was on it. He got that going to record. And Filipe stinks at this stuff.
Oh,
And I was just like, oh, but
I have
it's
to
on.
yell at you because my hormones are in check.
Well, you heard it.
Beautiful.
He can get you a prescription of vaginal cream. I think it was.
Right, myself.
No, that's illegal.
Okay.
She said that it calms you down.
Oh, gosh.
Right.
So is there something that you would like to leave that the viewers that are gonna see this and is there something like you said, I think now it's early detection, they show up a little bit earlier and thing, because I know prostate now was like 50 or 55, I think. Now it's dropped down to like 35 or something. No, see, I'm not a doctor, I'm guessing it.
Well, that's all. Well, we'll talk about that prostate cancer awareness month.
Okay,
But
but I
yeah,
was just saying, is there like
Well, I think that first of all, you should early detection is like breast protection.
Yes.
But for other take home is for women in general, if you feel alone, don't ignore it. Okay.
Mhm.
You should at least be seen or discussed with your primary or your gynecologist and be evaluated. It may be nothing, and the majority of time it is nothing. I want to reassure you, the majority of time it's not anything. But you shouldn't say, "Oh, I felt it 6 months ago, but I didn't do anything about it." Okay, but so I
Right.
think that that's the best take home I
Exactly.
can say. And I would
Yes.
say that cancer care in general and breast cancer it takes more than one clinician. I've given you my perspective from the surgical standpoint, but I couldn't take care of breast cancer without my colleagues, the radiation oncologist, the medical oncologist, who keep the cancer at bay and keep it from coming back. We know that, surgery alone isn't the whole treatment in regards to things. But that is many times the primary or that 80% of patients diagnosed with a cancer, not even breast cancer alone, will require some surgical intervention. So it is a component of it. But I really think that that's the thing. Early detection is the key. Even as, we're not going to detect every cancer at its as early as we'd like to, but that's our goal.
Exactly. And if you come to the breast center, we know just what to do. We have everything integrated. We call it multidisciplinary. We have since 2001, right?
Yeah.
And so we do offer screening, but also the workups for patients with the problems, like Kelley said. If you have a problem, we can coordinate your care and to get the help that you
And
need.
we have our high risk clinic. Those that are at high risk, whether they have a gene mutation, they have a family history that doesn't show the gene, but they're still at high risk. We see them so that they get proper follow-up.
Is there a geneticist at the breast care center?
We have a geneticist through the affiliated with Winchester. She sees cancer cases. She'll see for genetic counseling, not just cancer cases,
Okay.
but you can refer directly to her too.
Okay.
Yeah.
How do patients schedule that?
Usually you can make the order in your through Epic.
Okay.
To genetic consultation, and Sarah will get that, and she'll make either a telehealth with them.
Okay.
That's a
Or see
great
them.
service, honestly, for some
Yeah.
patients. They
You
really
know.
just need to know.
Yeah,
Mm-hmm.
That's good to
yeah.
know.
And sometimes insurance still will require that to be documented before they'll even approve it.
Okay.
What to be documented?
But that they met with a genetic counselor
Oh, I see.
To approve.
Oh,
for
right.
testing.
Okay, right.
Oh, okay.
Well, that makes sense.
All right.
All right. So listen, I once again extend my extreme
it's fine.
apologies on this.
I get it.
It's not fine because I had so many people and now everyone's gonna be upset with me. But I want to first, end with a thought, and I would like to say thank you, Dr. Wang. Thank you, Dr. Cornell. Thank you, Dr. Delphine.
It's Dr. Delphine Lui.
Delphine Lui.
Yeah.
So
Fine.
sorry.
That's all
I
right.
am so sorry. Delphine Lui. Once again,
You.
Filipe screwed it up, security tails. Delphine Lui. I want to thank you all for being part of this conversation. Breast cancer awareness isn't just for women's issues. It's a family issue, a community issue, and one that affects all of us. Before we close, I'd love for each of you to leave our listener with one message, one important message, and whether it's advice, hope, or a reminder about why early detection truly saves lives. I want something to stick, especially to my followers. So the city that I'm from has a high rate of breast cancer. It's so many females that I graduated with. I would like to say, and sad, that probably 40% of my classmates suffered this. And I know they're all logged on. I know they're on Facebook. And if you can give them one thing, hope, drive to keep pushing forward, I would love to hear what each and every one of you could say to them to motivate them.
Well, I'll start. I know you're nervous. We know you're nervous, but we still know how to take care of you. Our mission is to find breast cancer as early as we can, so that the smaller and earlier we can find it, then Dr. Cornell and my colleagues can take care of you the best. And actually, we can help you get back to your health so that you get this out of the way and get back to the life that you want to lead. And so early detection is the best protection. And don't be afraid. We see 26,000 women a year, and we understand. We get it. And
Yeah.
everybody there is very compassionate. We get very, very good reviews at our breast center for being compassionate. And we take care of you 360. So do get your care because it can save your life.
I mean, I think only to iterate, as I already said, breast cancer is for the majority, very treatable, especially in the earlier stages. It's not a death sentence, okay? And even with relapse and that, women are living longer with breast cancer. So I think there's a lot of hope and opportunity, okay, that is there. And that's why we are a team to treat it, okay? And I think we do a very state-of-the-art, probably, treatment through Winchester Hospital and the Breast Care Center.
Well, I'd like to echo what the other doctor said. Like any cancer though, I feel like getting information is important. A lot of my patients say, well, I don't want to know. They don't want to do the screening, whether it be genetic testing because there's a family history. They don't want to do the imaging because they just rather not know. And what I encourage is gather the information, and then we can go from there. Like information is power. So, and like they've said, the earlier you find something that,
Yeah.
it's treatable. So don't hide your head in the sand.
No, and don't be afraid to ask questions, okay?
Great
Don't
answers,
be afraid to
doctors.
ask questions.
So I want to ask you something personal. So when you had said 26,000, I felt a big emotion happen because like my whole family, females. I was raised by all females. Lost my dad when I was very young, so I have females. How do you guys deal with emotions? So many women, so many people that you develop this relationship with that you see every day. How do you separate that? And you don't need to answer if you don't want to, but how do you distance yourself from emotions?
Well, we have a mission, right? But we are also compassionate. We get it. So it's you can get it and still realize that you have a mission and you're going to get this done. You almost have to rise to the occasion when somebody's very nervous right? To calm them down.
Yeah.
It's almost like
You know.
have this duty and I don't know.
Something
How do you
clicks
do it,
and
Kel?
you just-
Something clicks. I mean,
Right.
I do a lot of, I do a lot of hand holding. I cry with them. We offer a lot of support services, which I think is key too, because there are numerous other issues that go on, not only dealing physically with the cancer diagnosis, it's emotionally, it can be financially, it could be the family members. There's a whole saga, and I can't take care of all of that. I've got to that's why we have a team. And that's why we built the breast care center. That's why, we do this in the way that we do that. And we have our, associates and, it's never easy. I mean, um, but, it's, it's what's better is doing this as a clinician is the more and more years that I've seen being here. This is my 28th year at Winchester, and I have patients that have been with me nearly 28 years,
So you
and
started
still.
when you were 12, though, at 5. So I thought
I was it was 13.
13.
Okay,
my
I guess.
Also,
So-
just a quick shout out to we have a big team, right?
Yeah,
And
yeah.
so it's
Yeah.
not just doctors, but also our nurses, of course,
Yeah.
our techs, and there's so much staff that
Yeah.
supports us.
But that's
a
the
good team.
joy of too, is seeing them come back, and they're still doing well. Okay, and we all, but that like I said, breast cancer, earlier we detect it, the better it's more of a, like to say, becomes kind of a nuisance or a part of your life. It doesn't necessarily mean that it's going to be the
Identity of you.
Yep.
How about you, Dr. Wang? Because I know it goes through the stages of primary care to the imaging and then finally the surgeon. How do you deal with the situation if you send someone there and all of a sudden you find out, oh my God, it's a readout, it's positive, especially with you own your practice and you're more involved with those people, with their family also,
Well,
because they come in as a group.
well, I have to give a shout out to the breast care center because usually they're the ones who are telling them first, and then I'm kind of like following up and like being like, oh, so I saw this, and how are you doing? These ladies, these doctors have already done the hard work, and I'm
Did not
They're-
know. I'm
report
sorry. I
them.
thought you detect them, then they go in there or whatever. You find some
Well,
during a site test. So
Well, she's very important. She refers them, right?
right.
Yeah.
The
Referral.
manager.
but usually they've already like gone the imaging and gotten that call, and they're already the process has started. And then I'm like calling and checking in on them.
Yeah, and I think from there, your primary provider knows the patient very well, can provide those other services that need, emotional support, and be there. I think it's a key component.
all right. Great. I really appreciate all three of you being here. And I please would love to have you all back. But it'll all work. I promise you, this is gonna be uploaded. So one of the biggest things is, and I'm gonna say it, everyone can leave questions on. If you have questions for Dr. Delphine Lui or Dr. Cornell or Dr. Wang, please leave them on and I'll make sure somehow, some way, we'll get in contact with them to come on back and to answer all these questions back, because I know this happens all the time. So I don't even know what more that I could say than thank you so much.
Mm,
It's been a pleasure. Thank
Thank you. Thanks for having us.
Thank you for a tremendous job.
Great to be
Oh,
here.
Thank
Three
you.
of you
Well,
doing
thank
it. I
you.
really,
Thanks
really,
for
really-
Winnie to
for hosting us.
hosting. Yeah, it's really great.
I am so sorry once again, my people. And I know. Hold on one sec. Let me see. Thank you, everyone, for joining us. Appreciate it. Thank you. Thank you, Michelle, Steve, John. Oh, I'm not even going to get through all yours, but thank you, everyone. You have a blessed day. Leave a question if you want for these lovely doctors, and they'll be back, and security tails will be set.
Oh, wait. Okay.
Right.
Well, I had a lot of viewers on here, but no questions. So how quickly are you